The Neepawa Health Auxiliary second session on October 10, 2023 was a presentation about palliative care from Prairie Mountain Health representative Sharla Murray. According to Prairie Mountain Health, palliative care is a commitment to whole person care for patients who are facing a life-limiting illness that cannot be cured. It is a commitment to whole person care that helps to relieve suffering and improve quality of life until the end of life. Murray mentioned that the only criteria to come into palliative care program is to be diagnosed with a progressive, life-limiting illness that cannot be cured, such as terminal cancer, chronic heart disease, and others. It's interesting to know that many communities have volunteer groups, including Neepawa, comprised of individuals who have interest in palliative care, where they provide companionship to palliative care patients, such as playing cards or watching TV, emotional support, listening to clients' concerns, caregiver respite, and bereavement support. Other volunteers also help with fundraising activities for the palliative care program and educating the community to make them aware of their services. There are a wide variety of services for palliative care, and it is important that people in the community are informed about it to make sure that those who are candidates of palliative care are able to access it, and to make sure that informed decisions are made by the family, healthcare representative, their physician, or the patient themselves.
Now, Sharla Murray is one of our palliative care clinical resource nurses for Prairie Mountain Health, and she's kind of near and dear to my heart because she started her career here in Neepawa. So she completed her nursing at Brandon General Hospital, and she was the last RN class from the hospital in 1995. She remembers feeling very grateful for her first term position in the recovery room in Neepawa, later moving to acute care, and then moved to Hamiota acute and a term in Russell chemotherapy. Sharla also held various casual positions in personal care homes, acute care, direct service nurse for home care case coordinator, and immunization nurse for public health in areas throughout Prairie Mountain Health. You've been busy. Currently, Sharla is one of the palliative care clinical resource nurses and has been for the last 7 years. Through this role, Sharla provides palliative care education throughout the region, supports clients who have a progressive life-limiting illness along with their families with providing resources, navigation of the health system, coordination of care, and symptom management. Sharla was born and raised on a farm outside of Hamiota and is now married with 2 children that are young adults and still lives in Hamiota. She enjoys sports, the outdoors, gardening, yoga, and kayaking in her spare time. We probably should have had Sharla speak first, but Maggie had to get back to Winnipeg, so because Sharla will tell us about what's available through palliative care as some alternative options that you've made. So welcome, Sharla.
Thanks, Judy. And I see lots of mentors out there, even my grade 1 teacher. I hope you don't mind me saying that. So I am pleased to be here today, and I'm going to talk about palliative care. So the first question is, what is palliative care? We have an approach to patient care for patients who are facing a life-limiting illness that cannot be cured. It is a commitment to whole person care that helps relieve suffering and improve quality of life until the end of life. So most people think of palliative care as when people are actively dying, those final last days or weeks of their life. But palliative care program can help long before that. Our program works with families and patients to help the best quality of life while they are dying. It's an approach to care. It's a team approach, and we use many different aspects of the healthcare team. We have volunteers, social workers, occupational therapists, physiotherapists, pharmacy, spiritual care, mental health, many different aspects help provide that quality of care. How can we optimize living as fully as possible in that time remaining, while also preparing for dying? So this is the bow tie model of palliative care, and it kind of talks about working collaboratively as a team. Also early referrals. As you can see, palliative care can start early in the disease management. We may not have as big a role, but as time goes on, we can support them a bit more so. So when should someone be referred to the palliative care program? The only criteria to come onto the Prairie Mountain Health Palliative Care Program is to be diagnosed with a progressive, life-limiting illness that cannot be cured. And there's some examples listed there, such as cancer, MS, ALS, Parkinson's, end-stage congestive heart failure, end-stage COPD, end-stage renal failure, end-stage dementia, just to name a few. As I talked about with the bow tie model, sometimes that early referral can allow for families to find out information about the palliative care program. Prognosis is not a factor. There's no life expectancy criteria that needs to be met with the Prairie Mountain Health program, and this can be different with other health regions. Winnipeg does have a prognosis factor of 6 months or less. It can also, the patients cannot be taking any chemotherapy or radiation at the time if they are to be referred to palliative care, or not wanting any resuscitation. So Prairie Mountain Health is different, and they don't have that criteria. So it doesn't, they can be taking chemotherapy, radiation, and can be resuscitation. So who can make a referral to the palliative care program? Basically anybody can. Physicians, nurses, home care, social workers, the patient themselves, family, spiritual care. Often it's the healthcare system that does do the referral, but it doesn't have to be. And physicians do have to sign that referral. So they do have to sign it to make sure that it's an appropriate referral. And this is just what the referral form looks like. So we have the patient demographics, a brief section on where the patient is, are they aware of the referral, their primary diagnosis, and what services would they benefit from. So this is the palliative care team in Prairie Mountain Health. Right now, Karen Fuller is our manager. Melissa Peters is the coordinator in the Brandon area, and she is full-time. The other three are clinical resource nurses, and Amanda Matheson will be starting a term for the east part of Prairie Mountain Health, which will cover this Neepawa area, and she starts that next week. I am in the west part of Prairie Mountain Health, and Jenna Zerba is in the north. We do have a regional palliative care volunteer bereavement coordinator who is Carla Mitchell, and she provides coverage for all of Prairie Mountain Health. So what is the role of the palliative care coordinator or CRN? So we receive the referrals and register the clients on the palliative care program. We register clients with the Palliative Care Drug Access Program, and I'll talk more about that later on. We make hospital and home visits to clients, support people with pain and symptom management, identify resources or supports needed to help support clients and family in their home, and offer any referrals if necessary. Support clients with their families with physical, social, emotional, psychological, and spiritual needs. Once we do receive the referral, we follow the patients in community hospital and serve as a resource for personal care homes. Sometimes common resources that we would refer would be home care, and they do a big portion of the hands-on care in the home, so we work very closely with the home care department. Occupational therapy, physiotherapy, dietitian, social worker, mental health, spiritual health can all be part of the care plan for the patient. We do have clients of all ages on the palliative program, but the pediatric palliative care out of Winnipeg does follow the pediatric patients, and we assist as needed. So the Palliative Care Drug Access Program is a provincial program available for Manitoba residents who are registered with a palliative care program. It covers the cost of most medications needed by patients, and it also covers the cost of home oxygen. This program is funded by Manitoba Health and is a subdivision of PharmaCare. Applicable medications will be covered, although not all medications are eligible. So some over-the-counter medications can also be covered with a prescription from the physician. If someone is taking Tylenol or a laxative that they take regularly, if their physician prescribes that with a prescription, that would be covered. How this works is the physician would send the form to us, and we would send it into Manitoba Health. The approval usually happens quite quickly, within a day, and then we would notify the patients. We would let them know that they've been approved, and then they can let their pharmacist know. So if they have any prescriptions to pick up, the pharmacist would be able to tell what's covered and what's not. This is just the form that it looks like. So the patient's demographics on the top, the physician would fill out that it would be appropriate and their primary diagnosis, and we would approve it. So palliative oxygen in the home, it is covered by the palliative drug program. And oxygen is considered a comfort measure in palliative care, so they wouldn't have to require any testing or criteria to be approved to have the oxygen. How that works, the concentrator would be in the home, and the home oxygen concentrator program would cover that, and the portable oxygen is covered under the palliative drug program. How that works, the patient would purchase the oxygen, the company would then be reimbursed through the drug program. When there is a oxygen to be set up in the home, the physician would send a prescription to us. We would send it on to Carica, which is the oxygen company. They would contact the patient to make arrangements for setup, and then that's how it would get initiated. So healthcare directive, I don't know if any of you have heard about those before. We often would review that type of documents with clients when we visit with them. It's a document that is similar to a living will or advanced care planning form. Those are all kind of similar types of forms. It allows the patient to document what their treatment, what their wishes would be, and be able to communicate it with the healthcare team. This form is important as it encourages conversations relating to clients at end-of-life choices, We encourage that they also involve their family and allow them to discuss things. Just it allows them to make their wishes known if they aren't able to speak for themselves. It doesn't always just focus on resuscitation, but you can talk about ventilation, feeding tubes, IV, pain medication, dialysis, surgeries, antibiotics. Kind of allows them to broaden their thoughts on what do they really want. The healthcare directive also allows for the patient to list a proxy, which is somebody that can make medical decisions for the patient if the patient isn't able to. So that's why it's important to have family involved if that's who they choose for their proxy, because they would be deciding what the patient would want, not necessarily what they would want for the patient. So this is what a healthcare directive form looks like. And you can see at the top, that's where the patient demographics would be. It allows them to list 1 or 2 proxies, and they can work consecutively or jointly, with restrictions or without, and then the treatment instructions. The patient would just have to sign and date to make it legal. And we do, we do encourage clients to share those forms with their doctor or their healthcare facility, but the original would go in an ERIC kit like this. It's an emergency response information kit, and those forms would be kept in there, so if they ever had to phone the ambulance when they're at home, they'd also can list their medications, allergies, all the important information would be there and kept on the fridge with the magnets on the back. So this is another form that's similar. It's called an advanced care planning form, and this is often used in facilities in Prairie Mountain Health, and they go hand in hand. This form has 3 options for goals of care. The first option is comfort care, where the goals and interventions are directed at maximum comfort, symptom control, and maintenance of quality of life, excluding attempted resuscitation. The second option is medical care, where the goals of care and interventions are for care and control of the client's condition. The consensus is that the client may benefit from and is accepting of any appropriate investigations or interventions that can be offered, excluding attempted resuscitation. So both of those are no resuscitation, and the third goal is resuscitation. So with the third option, the goals of care and interventions are for care and control of the client's condition. The consensus is that the client may benefit from and is accepting of any appropriate investigations or interventions that can be offered, including resuscitation. So we talk to the client about these options. Often there's a bit of a gray area between comfort care and medical care, because some of the interventions provide comfort. If they choose to have antibiotics, that's a treatment, but it also provides comfort. So I often encourage them to think about those types of things when they're feeling that out. And if they're ever admitted into hospital, these forms are often reviewed and allow them to change their mind at any time. So they can refuse certain things and change it as they go. So if the clients have decided they don't want resuscitation, there is a notice of anticipated death form that we can review with them. And it's a policy that was intended to ease the burden of an anticipated death by avoiding an emergency response when the patient dies at home. In order for this form to be completed, the person must voice and document they do not want resuscitation, and it's only offered to clients registered in the palliative care program. How this form works is it must be signed by the client, or they use their healthcare directive saying they don't want resuscitation. And It prevents any RCMP investigation or any emergency response. So if someone was to die at home with this form in place, we ask the family to call the funeral home, and then the funeral home kind of looks after things, and it prevents any RCMP investigation. When we fill out the form is faxed to the RCMP, the medical examiner, the client's funeral home, the physician would have a copy, and the patient would also have a copy, and we encourage them to keep it in the air kit on the fridge. Facility of preference. So it's a policy that allows clients registered with the palliative program to be taken directly to their desired hospital by prearranging this with their physician, even if the hospital chosen is not the closest health center to them. Or a closed emergency room. It's not foolproof, but the intent is to allow that client to go to their facility of choice instead of having them being ambulanced from site to site, if the local or their facility can manage their care. Sometimes with closed ERs, if clients are at end of life and nurses can manage their care, it allows for admission. But we also tell the families that it's not guaranteed. If the EMS pick up the patient and feel they need to be seen by a physician, they do have the right to take them to an open ER. And palliative care doesn't cover any ambulance costs. So this is just a slide on what the form looks like. Notice the facility of preference. We have the top part is where the client's demographics are, next of kin or contact person, and then the section that says the above named palliative client has requested end-of-life care at Neepawa Hospital or their facility of choice. And if the care needs cannot be met by this facility, the client has been informed that he or she will be transferred to another facility for care. So the physician would sign it. The client would also get a copy and keep it in their ERIC kit, as well as anyone else that's involved with the client's care, such as home care, and palliative care would have a copy as well. So the Prairie Mountain Health Palliative Program has a volunteer and bereavement coordinator, as I had mentioned earlier, Sharla Murray. She's our social worker that helps arrange the volunteer teaching sessions and provide guidance to the groups as needed. Many of the communities have volunteer groups comprised of individuals who have an interest in palliative care. They can provide companionship such as playing cards or watching TV, emotional support, just listening to clients or validating their concerns, sometimes legacy work, caregiver respite and bereavement support, but they also help raise money for the palliative program, as also education, just educating the community to make them aware of their services. We do have a group in Neepawa here, and they're working on getting more groups in the north. Brandon has Westman Hospice that does their volunteer groups in Brandon. The referrals for clients that are in the community, they would need to be referred to the palliative program, so they would be registered. But the volunteers can be accessed in hospital without making that referral, as long as the patient is considered a reasonable palliative diagnosis. So what are some of the common symptoms in palliative care? So obviously pain is a common one. We do have standing orders as well as symptom management guidelines that staff can follow throughout the region for best practice of managing. Constipation, it can often occur with some of the pain management medications, but also a change in activity and diet as diseases can progress. Nausea and vomiting can occur also. It can be related to pain, a side effect of medication. And there's lots of different medications that it can be used for nausea depending on what's causing it. Also, sometimes we use different routes than the oral route to help manage with nausea, because the last thing you feel like is swallowing a pill if you're not feeling well. Poor appetite is common, and we often have to educate that sometimes that's due to that disease progression. And it's very common that the body just can't use the nutrients anymore. Fatigue and weakness, that's also common with patients that are declining, as well as depression and anxiety. They, if they affect the client's quality of life, sometimes it's appropriate to start on an antidepressant, even though it's very natural and normal to feel the way they're feeling. But if it's causing concerns day to day that they're not managing, then it's important that those get addressed, as well as coping mechanisms, talking to anyone. We try to help them out in those areas. Shortness of breath can be common as well, and we had mentioned earlier about the home oxygen. Sometimes we encourage fans. They say that a fan blowing on your face can be equivalent to 1 to 2 liters of oxygen, or an open window can be enough. Also, the opioids such as morphine or hydromorph can help the patient feel less short of breath. So there's different things that can be help the patient feel less short of breath. This is a consult line, so if there's ever any symptoms that they're having difficulty managing, or that's the physician is needing to consult, there is the Winnipeg RHA Palliative Care program that have a 24/7 consult line, so they can call and just see if they can manage symptoms any better with some of their suggestions. So compassionate care benefits, this allows family members up to 6 months off work to be able to provide care or spend time with a family member who has been given a prognosis of less than 6 months. It is a federal program, so anyone across Canada can access it. This also adopts a broad view of those considered to be family members. You might have a neighbor that's like family that might be able to access this benefit. So as long as the family has a job that pays into unemployment, they can take that time off. And it's also flexible from family member to family member. So if you took 2 months off and your sibling took 2 months off, as long as it doesn't exceed the 6 months, that they can take that time without using holidays or sick time. So Camp Bridges is a camp it's a weekend camp for bereaved teens and children ages 7 to 15. And death experience does not have to be a palliative related death to apply. So anyone who's experienced a death, it could be a car accident or a suicide. It doesn't have to be someone that's been in the palliative care program. It's no cost to campers. And they do regular camp activities, but honor memories of loved ones and provide an opportunity for children to grieve and be able to relate to other kids who have had similar experiences. So we had kind of a lull with COVID, but we were able to have camp again this May. It's always the last weekend in May. We do have about 20 volunteers that they do a little training session just before camp. And we accept 40 campers, And the locations are usually altered. Last year we had it at Circle Square Ranch in Austin. So these are some of the resources. We did have Kleenexes on your chairs from Canadian Virtual Hospice, and they have a lot of information on palliative care. They even have right now, I think, modules for caregivers that they can take to help learn for providing care at home. So does anybody have any questions?
Seeing none, just for the drug program though, Sharla, I was just wondering, like you said, there's no life expectancy time limit to be referred to palliative care, but is there to be on the drug program?
No, nothing is written.
Okay.
Yeah. Yeah. I think at one point they wanted it to be the 6 months because that's kind of the,
Thinking back to when my
but
parents were
there's,
still.
yeah, it's not documented, that, so yeah. And I think there's a lot of people that don't have the drug program at all. Like sometimes they don't use it, or, you know, if they go into a facility. I think the idea behind the drug program is if you're in facility, your medications are covered, but if you're at home, this is a way to help support you at home by covering some of those medications. Yeah.
Anything else from anybody? If not, we had another great presenter that just answered all the questions. So,
Yeah,
thank you.
anything else you're looking for?